CHÉOS exists to improve health outcomes for BC, Canada, and the world. Learn more at chaos.ubc.ca.
And it's my privilege today to introduce Dr. Ricky Turgeon, who is the Greg Moore Professor in Clinical and Community Cardiovascular Pharmacy, which is at the Faculty of Pharmaceutical Sciences at UBC. Of course, he's also a scientist with CHÉOS, and he's clinical pharmacy specialist in the heart failure clinic at St. Paul's Hospital. It's called Pharm HF, and it's a pharmacist-led clinic for heart failure medication optimization. Dr. Turgeon received his bachelor's degree in pharmacy from the Dalhousie University, and then he did his pharmacy residency here in the Lower Mainland in the Pharmacy Services Residency Program, and then he completed his PharmD at UBC. After that, he did a postdoctoral fellowship at the University of Alberta, Faculty of Medicine, in the Division of Cardiology. Ricky's very active in research, and his research centers on identifying and narrowing evidence to practice gaps in pharmacotherapeutic management of various cardiovascular conditions, but he does focus on heart failure and coronary artery disease. A particular area of interest includes developing and evaluating point-of-care decision aids and other decision support interventions that can help guide patient and clinician shared decision-making. Welcome, Ricky, and I'm looking forward to your presentation.
Thank you very much for that introduction to Dr. Humphreys. And let me share my slides here, and you can give me just a thumbs up. Oh boy, I'll just assume you can see my slides.
Looks good.
So thanks. Okay, fantastic. Hi, everybody. I'm excited to see many fellow researchers and also many pharmacists and other clinicians on the call. So looking forward to presenting and then connecting and speaking with all of you. So I'm going to be talking today about some recent work that we've done, and try to put it into context first. So we're going to start off by talking a little bit about medication non-adherence. We'll define what it is. We'll talk about why it's a problem in people who've had a heart attack or an acute coronary syndrome. We'll briefly talk about a bit of a statistical technique called group-based trajectory modeling, which will lead us into our discussion about a recent project that we've just recently completed and published. And then we'll talk about some musings in terms of next steps, both in terms of clinical practice and in terms of research. So first thing I want to talk about is defining the problem a little bit about medication non-adherence in patients after a heart attack. So very back to the basics in terms of medication adherence. What is it? It's a problem that was identified and discussed for a long time now, since the probably 70s or 80s, that we've identified that people might not be taking their medications. And so the WHO back in 2003, almost 20 years ago, put out a big report about the issue of medication non-adherence, particularly in patients with chronic diseases. So what it is and what the problem was. And so this definition is taken right out of that report from about 20 years ago, which defines medication non-adherence or medication adherence as the extent to which a person takes a medication, or the behavior in taking their medication, and how that corresponds to sort of the agreed upon recommendation or prescription from a healthcare provider. Now, that's admittedly pretty paternalistic in my view in terms of the language. We've tried to become less paternalistic as clinicians in terms of how we talk about taking medications. We've changed from talking about it as compliance to adherence. But really what it boils down to is clinician and patient make a plan to start a medication, and then the extent to which that patient takes it, both in terms of starting it and continuing it for the intended way it was taken. There's many factors that play into medication adherence. Specifically, there's a lot of different barriers that can come between a patient and being able to take their medications. These span sort of 5 key domains that really revolve around our healthcare system, the patient themselves, and then the medications and the conditions that they're taking them for. We try as much as possible in healthcare to try to operationalize certain definitions. So although I've given you a bit of a fluffy definition of medication adherence, we can't really use that to measure adherence and to study it and to identify it in practice. So how we've operationalized traditionally medication adherence is around using a cutoff. So in cardiovascular disease, in particular, we often use an arbitrary cutoff of 80%, meaning if I take at least 80% of my medication doses in the expected time, then I am considered adherent. And if I take less than 80%, I'm considered non-adherent or poorly adherent or having poor adherence. And we'll talk a bit more about that cutoff and how we can change some of these things. So if we use that arbitrary cutoff in cardiovascular disease, then the problem of medication non-adherence is quite common. And so when I'm talking about medications for cardiovascular disease kind of across the board, only about 50 to 60% of patients are considered adherent to their cardiovascular medications, which means about half of people are not taking their medications fully as intended all of the time. Now, in the world of acute coronary syndrome, or patients who've had a heart attack, this is an area where we've got a lot of medications and routinely will prescribe at least 6 medications to these patients on discharge just for that heart attack and to reduce the risk of having a recurrent heart attack. That doesn't even account for other medications that people might be taking for other health conditions. So when you think about it, the more medications you're taking, the more opportunities you have for not taking your medications or for not taking them as prescribed or as intended. What I want to just raise here is the fact that on top of this sort of routine 6, or the 6-pack as we call it in the Maritimes, there's at least 8 other medications that a patient might be prescribed at that point in time as well, depending on select characteristics of that person. So if they have a lot of issues with diabetes, they may be prescribed other diabetes medications. They may be prescribed medications for inflammation and for different kinds of cholesterol disorders. And so very quickly in patients who've had a heart attack, we can run into a situation of a lot of medications, which might lead to some confusion and access issues for patients. For the sake of trying to simplify and hone in on one problem, we're going to focus on one single class of medications in the study that I'm going to talk about and some of the discussions around that, which are these medications called P2Y12 inhibitors. So P2Y12 inhibitors are essentially a class of medications called antiplatelets, and essentially these reduce the risk of clot formation. We use them in patients after a heart attack to reduce their risk of a recurrent heart attack from this clot formation. We prescribe these medications on average, typically for sort of a routine set of 12 months, and then potentially longer for some patients. At least in the time period where we're going to be talking about from the previous study that we're going to talk about, 12 months was fairly standard. Sometimes we use a shorter period of therapy if patients are at really high risk of bleeding, or we might use an extended period of time if patients are at high risk of clotting. But for the majority of patients, the intended duration of therapy for these medications is about 12 months. And it turns out that if the intended duration is 12 months, then we have a set time frame that we can look to see how often patients are successful in taking their medications for that period of time. And it turns out, as with other cardiovascular medications, that non-adherence is very common with this group of medications. And prior literature, kind of spanning many Western countries, has shown that non-adherence is present in about 55% of patients who are no longer taking their medications by that end of that 12-month or beginning of that 12 months. So I've been interested in this class of medications for a while now. During my fellowship, my research and clinical fellowship, I was really focused in around the different types of P2Y12 inhibitors. And specifically, a couple of years ago, we did a study looking at different P2Y12 inhibitors, specifically a medication called Ticagrelor and compared to a medication called Clopidogrel. And our rationale for doing this was that there was really high quality evidence from a randomized controlled trial that was published in 2009, but that in contemporary times, a lot of things had changed in terms of how we managed heart attacks, in terms of the types of interventions that we use outside of medications. And also the fact that some of the things that we do in practice don't always line up with randomized control trials, both as us as clinicians, as well as patients and their ability to take medications. And so back then we looked at Ticagrelor, which was the newer, sexier medication, and compared it to the old tried and true Clopidogrel to see how these two compared. And specifically, adherence comes into play here because Ticagrelor is newer, it was more expensive. It has its own range of specific side effects that could be potentially barriers to adherence for patients. And so our primary focus with this study was looking at the comparison between these two drugs. But it's while working on this project that I started getting more and more interested in the concept of adherence to these medications. And so just to give you a glimpse, so this was a study using a registry called Approach in Alberta, which captures essentially everybody who's had a coronary angiogram, which is a common test done after a heart attack. And so captured a large number of people with a heart attack in the province of Alberta. And we used medication prescription fills using an administrative database in Alberta to identify medication adherence. So by doing it this way, we weren't able to actually measure patients' actual adherence to their medication. We couldn't see them put the tablet in their mouth. But we could use a surrogate measure, their prescription fills from the pharmacy, to see how often they actually had access to their medications. And so we used a really common measure of medication adherence in admin data called the proportion of days covered, which essentially is a percentage measure of the percentage of days or time where a patient has access to the medication, where they could theoretically be taking that medication. And naive as we were back when we were doing this study, we used the standard dichotomous 80% or more you're adherent and less than 80% you're non-adherent to define adherence back there. When we did that study, we found that about 74 to 82% of patients were adherent to these drugs, and contrary to our beliefs, Ticagrelor, at least in using this measure, patients taking Ticagrelor were more adherent or more often adherent than those taking Clopidogrel. And what we found when we used this dichotomous break cutoff, we found that better adherence was associated with better cardiovascular events or lower risk cardiovascular events or better outcomes. That's not too surprising. That's a pretty consistent pattern seen in the literature. And so this wasn't breathtaking or groundbreaking in terms of results. But we were interested then to look to see, well, what if we don't just look at it with this arbitrary cutoff? What if we look at the whole span of adherence? How well does adherence track to outcomes? And so we did that. We looked at this measure of adherence continuously. And just to orient you to this graph, the x-axis is your percentage of adherence going from 0 and capped at 100. Keep in mind, patients can fill more prescriptions than they need in a set time frame, in which case they would be over 100% adherence. And traditionally, we will cut that off at 100%. But that's the x-axis, and your y-axis is your hazards ratio for cardiovascular events. So the higher the line on the y-axis, the greater the risk of cardiovascular events. And interestingly, what we found was that as your adherence decreases, at least all the way to about 50, your risk of cardiovascular events seems to go up, which tracks with our other analysis that I presented earlier. What didn't really make sense, though, and was surprising to us, at least on an observational basis, is that actually once your adherence started going below 50%, your risk of cardiovascular events actually started to go back down again. So clearly we're missing something in the data. Either it's hopelessly confounded, or we're missing a pattern here that, that we can't quite capture just looking at it this way. And so for a while we were a bit puzzled and left it at that. So we found that, okay, good adherence associated with lower cardiovascular events. But there's no clear dose response here, at least between the percentage adherence and cardiovascular event rate. So we were thinking, well, clearly we need a better way to identify some of the patterns of adherence here that we're not capturing. And so I started to trying to think, well, how could it be that somebody who has 50% adherence is actually a higher risk of cardiovascular events than somebody who's adherent maybe 25% of the time? And so we started thinking through some potential hypothetical scenarios. And this graph here just illustrates that a bit. It's important to keep in mind that after a heart attack, your risk of a recurrent event or dying from that heart attack is at the highest at the very beginning. So you're at highest risk of a recurrent event right away in the first few days, in the first week. And then over time, that risk of recurrent events actually goes down. It's never low, but it goes down from what it would be in the first few months. And so we started thinking, well, theoretically, if somebody is actually adherent to their medications at the very beginning and then drops off later, that patient may have better cardiovascular prevention or protection than somebody who upfront is non-adherent and starts picking up or starts adhering more to their medications down the road. And so that's what this illustrates here, where you've got patient A who maybe filled their prescription once for a month, and then for many potential reasons, maybe couldn't afford the medications because these aren't cheap, until they could get a job and start reaccumulating wealth or becoming eligible for insurance again at 6 months. And maybe they're adherent after that, so that if they took their medications for 6 out of 12 months, they'd be adherent for 50% of the time in that first year. And compare that to somebody like patient B, who maybe took their medications for the first 3 months and then said, the heck with it, and it stops there. That patient is adherent only 25% of the time, but they're taking their medication during that highest risk period. And so conceptually, that makes sense, or that fits with what we know in terms of medication adherence, which is very much a complex set of behaviors. So to be successfully adherent, you actually have to start the medication. You have to take it appropriately for the intended duration, and then you have to continue it for the intended duration. So you can imagine that break at any points of those break at any point there in terms of that process can lead to different types of patterns of medication adherence, or non-adherence, in other words, is not just one entity. It may be different sort of entities depending on where the break happens in this process. So for a bit, didn't really know how to really explore that well. And then I came across this statistical technique called group-based trajectory modeling. So I'll talk a little bit about that before we talk about how we used it. So for the non-stats folks in the room, so group-based trajectory modeling, or GBTM, is a way of identifying subgroups based on the data that you have, and specifically identifying subgroups based on their trajectory on a certain variable or outcome. It's a form of latent class modeling which uses longitudinal data. So it's very much a data-driven technique. You put data in, it spits out a technique, it spits out groups or subgroups. And so there is the need there for the content knowledge and certain statistical criteria to make sense of the groups that come out. Historically, this is actually used at the very beginning in psychology. So this was used to identify trajectories of physical aggression in adolescent boys, and has been adopted in many areas, including in medication adherence or medication use type of research. There's a few important assumptions that go into this. Like I said, it's data-driven, and this technique identifies subgroups. That's what it's best at doing. And it assumes that the subgroups are present. And so it will identify as many groups as you tell it to. So you really do have to guide it using prior knowledge as well as statistical criteria for degree of fitting. This is a relatively simplistic form of latent class modeling, in the sense that it assumes that essentially everybody who belongs in a certain subgroup are relatively homogeneous. So it is not very good. It's good at identifying differences between groups, but not within a group. So it's been used quite a bit now in the world of medication adherence. Systematic review done in 2020 had identified over 20 studies that span various disease states, anywhere from cardiovascular disease, diabetes, breast cancer, schizophrenia. And so there's been several ways in which it's been used in this space. What you're seeing on the graph on the left there is one of the ways in which we visualize or use GBTM. So it spits out this trajectory graph. So again, just to orient you, X is time, Y-axis is percentage adherence, and those various lines are different medication adherence trajectories. So that straight horizontal line at the very top, that going from 100% is a group of patients who are 100% adherent the entire duration of that study. Whereas, for example, the yellow line illustrates somebody who is adherent at the very beginning, but very quickly drops off and discontinues their medications. And so we can use GBTM to identify these trajectories. We can then identify how frequent they are. So we can see, how big of a problem is it, or how prevalent is it in a given group. We can identify potential risk factors. We can relate the trajectory groups to potential outcomes. And then in theory, and the panacea here, the golden goose egg, would be that we could target interventions to either prevent these trajectories or switch them around or fix them once we identify them. And just to illustrate that, just in a different way, as with all sort of latent class or subgroup modeling, what you're doing is you're taking a relatively undefined population or sample. Here we might have individuals who are just labeled non-adherent, and that might include people in like the person in green here who forgets a dose every once in a while, or a person in yellow who stopped taking their medication after 3 months, or somebody like the person in red here who never started the medication to begin with. We could do what we're doing right now in the world of medication adherence, which is kind of treating them all relatively the same, which is not particularly effective. Or if we can identify some of these actionable subgroups, then in theory, we could tailor an intervention to them. So for example, maybe the person who forgets a dose every few weeks or a few days, maybe all they need is a daily text message reminder or blister packing or some fancy medication packaging that can help them take the medications. Whereas somebody who never started taking the medication in the first place, maybe they didn't appreciate the value of it or didn't agree with the value of it, in which case you might have something like shared decision-making up front to see if that is something that they want to do or an intervention that they want to take. Or you might have a healthcare navigator, which can help them navigate through the issues of medication and insurance and all of the complexities of our healthcare system. That's the goal. That's the dream. So let me tell you a bit about how we tried to do that and what we were able to identify in our world in cardiology. And so this study that we did took us a couple of years to get it all out there, and was just recently published online, the European Heart Journal. If you want to read it, I'm happy to share a PDF or a copy of it. But we'll talk a bit about some of the key messages from that study now. Just to reiterate that the purposes of doing what we're doing in this study are very similar to some of the underlying reasons to do GBTM in the medication adherence world. So first of all, we want to identify the types of trajectories to these antiplatelet medications after a heart attack. And just to note that we were specifically targeting patients who were treated with percutaneous coronary intervention, or PCI. You may know this as putting in a coronary stent. So it's where we actually go in. I say we, I mean a physician and not me, the pharmacist, but it's where a healthcare provider goes in, opens up the coronary vessel with a balloon, and with or without the placement of a stent, which is essentially a cage that keeps that coronary artery open. So we kept it to those patients because those are patients who certainly had a heart attack and had a meaningful intervention implemented. So we knew that these were patients who clearly were our target population who would be receiving these drugs. And so we first wanted to identify the trajectories of adherence, and then we followed that up with trying to identify how frequent they were, and then see if there were any specific risk factors for these different trajectories, and then again linking them to our cardiovascular events to see how these trajectories were associated with those. So just to note that we use the approach registry here again, which is a population-based registry of individuals and with coronary procedure or heart procedure. And so these are patients with heart attack, essentially everybody who had a heart attack in Alberta. And we looked from 2012 to 2016. And so we identified about 12,000 patients. And so with GBTM, essentially you start off by defining what your longitudinal outcome is going to be. In this case, we were looking at medication adherence over time in the first year after a heart attack. And so we started by creating these so-called supply diaries. So we took the prescription fill data from our outpatient pharmacies in Alberta. And then we sliced every month from month 1 to 12 after a heart attack. And so we were able to identify what the adherence was in each one of those months. We then used a dedicated software package called ProcTraj in SAS to essentially model different trajectories using different numbers of groups. And so you start from the simplest model of 2 groups, and then you keep going. And from there, you identify the ideal model based, one, on clinical meaningfulness of the model. So do they make sense? Are they useful? And then also on specific statistical criteria to see if they actually predict the behavior or trajectory that you're looking for. So just to show you sort of what that output kind of looks like, this is the very simplest model. It splits off the whole sample into 2 groups. So you've got here group 2 here in green, which is fairly persistent adherence. And then you got group red here, which has some intermediate adherence at the very beginning and that rapidly drops off over time. And then you keep going essentially in terms of number of groups. And what we can see here is that the 3-group model started producing different trajectories that were still clinically meaningful or made sense from a clinical perspective. Same thing with the 4-group model. Once we started getting at the 5-group model, we were getting some similarities between the groups. And once we went beyond that 6 and 7 groups, you're starting to get diminishing returns in terms of the numbers of groups. So the additional groups that we were generating were very similar to the existing ones. And on top of that, they were becoming smaller and smaller. So less than 5% of the overall sample were being represented within these groups. So from a content perspective, the 5-group model made the most sense and provided the most value there in terms of identifying actionable trajectories. And so that's how many subgroups that we ended with. And I'll just point out as well that the statistical criteria kept improving even after we went to seven groups. So we narrowed it down to 5 to try again, based on the content knowledge there. So from that study, we found 5 key trajectories in terms of medication adherence. Fortunately, the most frequent one, group 5, was those patients who had persistent adherence. So those patients essentially continued the medication and at least had access, continued filling the medication for the entire 12 months of the study. And the next most common was patients with a gradual decline, and that's this blue line here. So strong, high adherence at the very beginning that steadily dropped off during the course of the study. And then the 3rd most common group was the early consistent non-adherence group that we called it, in 11% of patients. These patients had sort of low to middling adherence at the very beginning, so may have filled off basically a month's worth of the prescription and then very quickly stopped filling the prescription. And then the next more common groups were patients who actually took a while to even start the medication. So even though they just had a heart attack, they were just prescribed a new medication, they maybe didn't start it until 3-4 months down the road. And then finally, the rapid decline group, which is, again, people were highly adherent at the very, very beginning and then very rapidly stopped taking their medications. Our next step was to try to identify potential risk factors or trajectories for those trajectory groups. And I put the table here, not so that you can actually go and eyeball all of the different potential risk factors that we analyzed. But I simply put it to make a point, which is to say that a lot of the different risk factors that we identified here were risk factors for multiple different forms of non-adherence or the different trajectories of non-adherence, meaning there was really no smoking gun for one risk factor being closely tied to only a single one of these trajectories. For example, material deprivation, which is a surrogate out measure that we use in administrative data for socioeconomic status, was associated essentially with every one of these non-adherence trajectories. So it wasn't tied to any singular one. And in fact, if we do a bit of a ugly Venn diagram of 4 groups, what we can see is that there's substantial overlap across the different trajectories, and only a few of them actually end up only a few of these risk factors end up being unique to any one of the groups, which is not very clinically actionable. And it's also not very amenable to a clinical prediction model, for example, to try to identify these trajectories based on the available information in admin data. And so the final step in this study was to try to identify the association between trajectories and subsequent cardiovascular events. And so we used cost proportional hazards regression in order to try to identify these associations. And we'll talk a bit about this, but we also looked at a subgroup of interest in terms of what kind of percutaneous coronary intervention was delivered to the patient. And I'll talk a bit more about that. So here I just want to illustrate those patterns that I showed you, those trajectories, but in a sort of 2D or kind of crushed plane. And what I want to point out here is simply to highlight that in terms of what we see here with these groups, in the highest risk early phase of risk for a recurrent cardiovascular event, groups 5, 4, and somewhat 2 here are relatively adherent during that early phase. And so if I were just a priori making a prediction about which groups are going to be associated with cardiovascular events, I would say the group 1 and 3 would be the most likely because they're the least likely to be taking medications during this time, during that high risk period. So in the face of that, these are the results in the overall group of patients after a heart attack that we found. What we found was that there was an association between the rapid decline and delayed initiation subgroups or trajectory groups and an increased risk or higher risk of cardiovascular events in those patients. But interestingly and somewhat surprisingly, we didn't find an association overall with the early consistent non-adherence group. Now, what we did, when we did look back, we found that there was actually an interaction between what kind of stent the patient received and this association. And so just to point that out, so typically nowadays, we'll use what's called a drug-eluting stent in these patients, meaning it's a stent, so it's that cage, and it's coated with medication that helps to prevent essentially regrowth of plaque or tissue around that stent. And so we use those to reduce the risk of needing future procedures. And so drug-eluting stents tend to be the ones that clot more early on. And so we very much want to give these P2Y12 inhibitors to these patients. So it's a very strong indication to use these medications, and particularly 12 months. If we have a patient who's a very high risk of bleeding, we'll tend to use either no stent at all or a bare metal stent, which has a lower need or need for shorter duration of these medications. Essentially, what we found here was that when we actually stratified our analysis based on the type of stent the patient got, we again found a very strong association here between early consistent non-adherence and cardiovascular events in that group who got the drug-eluting stent, because those are the patients who were intended to be on the medication for that full 12 months. Whereas those patients with a bare metal stent or no stent at all, actually generally the indication would be for a short duration of that P2Y12 inhibitor. So it wasn't that the patient was non-adherent, it's that they weren't intended to receive the drug for that long in the first place. So overall from this study, what we found were 5 key trajectories of medication adherence to the specific class of medications. Unfortunately, we found that although we could identify risk factors for these non-adherence trajectories, there wasn't a smoking gun. There weren't any strong predictors that we could use to try to identify these before the fact. So before the patient was actually non-adherent or following one of these trajectories. We did find an association between some of those trajectories, particularly those that had low use of medications very early on after the cardiovascular events. And subsequent cardiovascular events. So then the question is, well, how do we use this, or what's the implications of these results, both in practice and in terms of future research? Well, I think ideally what we would have, the dream, as I mentioned earlier, is that we can act on these results. And so the ideal situation would be that we can predict these trajectories so that we can avert them in the first place, so we can incorporate interventions to avoid them. As I kind of alluded to earlier, a lot of the medication adherence research that's been done so far has largely been disappointing. And oftentimes it's because we're implementing these interventions indiscriminately, and we basically end up implementing an intervention to patients who otherwise would be fairly well adherent. And that's certainly the case in the research in patients after a heart attack, where most of those patients, like here, 55% were persistently adherents. Those are not patients who will benefit from our interventions. They might get annoyed because we're nagging them or implementing other interventions that they otherwise don't need. So the ideal situation here is that we could identify somebody who could follow a suboptimal trajectory and try to implement interventions to address the barriers to adherence. Just to highlight some of those examples, as I mentioned earlier, if you've got somebody who never started in the first place, maybe it's an access issue, either because of cost or transportation or other issues that prevent them from actually going and receiving the medications, then something like I mentioned, something like a healthcare navigator or a clinical pharmacy consult or something that links that patient to those kinds of resources might avert that kind of trajectory. The problem here with the P2Y12 inhibitors, like I said, is we didn't identify any strong way, at least from an administrative database perspective, to identify those trajectories before the fact. So in terms of P2Y12 inhibitors after a heart attack, one of the key things that we need to keep working on is actually identifying some of those potential predictors. And I don't think we're going to find it in this bird's eye view administrative data. Unfortunately, I think it's going to be more clinical data and sort of questionnaires and those sorts of things to identify potential barriers for patients, for example, before they get discharged from their heart attack. Something that is interesting and promising, though, is for those types of drugs where or for those patients where you identify a suboptimal trajectory, there is some evidence supporting motivational interviewing for those patients. And so this is just from a small randomized control, quasi-randomized control trial. And they took patients who were prescribed a statin medication, these cholesterol-lowering medications to reduce the risk of cardiovascular events. And they identified that these patients were already following one of these non-adherent trajectories. They're defined slightly different from the ones in our study, but globally, these are similar to what we would find. And what they did is they identified patients who were following those trajectories, and they designed a motivational interviewing intervention that was targeting the potential barriers that might be associated with those trajectories. So for example, somebody who discontinues the medication right off the bat, it may be cost related, could be side effect or transportation related. So they had pharmacy students who implemented motivational interviewing and specifically targeted those kinds of barriers. And ultimately, when that was compared to usual care, resulted in better adherence to medications over time. Here they looked at adherence at 6 months using fairly crude measures of adherence, but overall it resulted in better adherence. So motivational interviewing here, and especially targeting those potential barriers, would be a very interesting way to an important next step, essentially, especially with these medications. Now, I think that identifying these trajectories can be complicated. So we had admin database and we did our own analysis, but that can be difficult to do for a clinician. Oftentimes we'll get, for example, Pharm records, and we'll try to piece together the gaps in terms of how often patients were non-adherent, and that's not very scientific and does take a lot of scrolling through reports. But this idea of using EMR-based nudges or alerts, I think, holds a lot of promise. This is just from a recent study done in the world of heart failure and not specifically for medication adherence. But this was looking at an area where medications tend to be underprescribed, and it randomized clinicians to either receiving an alert or to usual care. And the alert was as simple as telling the clinician, gathering information from their chart and telling them, your patient has this condition that's treated with these medications and they're not receiving the medications. Do you want to prescribe them? And so we could easily implement something with adherence where it extracts the information from Pharm, generates one of those trajectory graphs and says, your patient is in the discontinuation trajectory. Do you want to help them modify their trajectory? This trajectory is associated with these barriers. Do you want to talk to your patients about these types of things? And so at least in the heart failure world, that has resulted in increased prescribing of appropriate medications. And so my musings here are that that would be a clever way to identify these patients, and certainly a better way than me trying to create my own little manual graphs out of these PharmNet records, and might help to identify these patients so that we can actually make these interventions rather than implementing an intervention across the board to everybody. So those are some of my musings, but I'm looking forward to your questions and hoping for some good discussion.